Welcome to the Dr. Lexi Show, where I take pregnancy topics and break them down into simple terms to help you advocate for yourself and your pregnancy. I'm Dr. Lexi, a board-certified OBGYN and maternal fetal medicine specialist, which just means a high-risk pregnancy doctor. And today we have a really special guest on the podcast, Dr. Sarah Pachtman.
I also am a maternal fetal medicine specialist. I practice obstetrics and high-risk obstetrics and maternal fetal medicine.
So we're going to tackle a couple questions I ask most everybody. Okay.
Looking forward.
All right.
I hope I answered them correctly.
All right. These are straightforward. Okay. So there are 10 of them. So what does the abbreviation OBGYN stand for?
Obstetrics and gynecology.
Perfect. See, you're doing great.
Yay. One down
One
so
down.
far.
What do the letters MFM mean?
Maternal fetal medicine.
Lovely. How does a provider come up with a due date for a patient during their pregnancy?
It depends on few things. If it's a reproductive endocrinology, ART, which stands for assisted reproductive technology patient, then I use the either transfer dating or the conception dating for IVF or IUI, and I don't deviate from that. If it's not, then you use last menstrual period along with a first trimester ultrasound exam where you measure the crown rump length of the fetus and compare it to the first trimester or the estimated due date that's given by the last menstrual period. And if it's within 7 days, I keep the last menstrual period dating. If not, I redate based on my spectacularly accurate first trimester ultrasound.
Do you feel like it's a board exam right now?
Yes, and I'm kind of
so good,
and I'm kind of loving it. But wait, hold on.
It's great.
If it's a second trimester, yeah, then I can do biometric ultrasound dating.
There you go.
Because a lot of times they don't remember an LMP or they have
Mhm.
irregular periods
Mhm.
or PCOS.
Mhm.
You can have longer cycles or no cycles sometimes.
So confusing.
Very confusing.
This is one of my most favorite topics because if I were the patient and I asked like, what's my due date? I would be super confused if I didn't go through IVF or some type of assisted reproductive technologies and they kept changing my due date or I saw different due dates. I would be uber confused. And I read ultrasounds a lot now. And as a maternal fetal medicine specialist, in my opinion, I feel like an OB provider should have figured out a due date before they come to maternal fetal medicine.
100%.
You should see how many times I'm redating pregnancies. Yes. Neither here nor there. But remember, too, everywhere in the U.S. is so different on who does what scans.
Yeah.
So sometimes the MFM offices are doing first try scans, like I'm talking dating scans, or they're doing a scan later and the OB has never done an initial scan in their office. It's very interesting. So I noticed this was a common issue. So I came up with a handout. I'll give you the little handouts and stuff. It's really for a patient to see the chart on exactly what you just described. Like, hey, this is when I told them my period was. I went in, this is what they told me my baby measured. So would they change the date? Yes or no?
Yeah.
And it makes it a little more simple. I have to look at that chart all the time because it's like greater than 7 days, greater than 10 days, greater than 14 days,
Right.
all these little things. And almost always it's right on the borderline, and then you have to say, are your periods regular? Are they irregular?
How long is your cycle?
How long is your cycle? So it's a complex answer. It's a simple answer, but yet it has complexities to it, I guess I would say.
The other thing, now that I do also general OB that I have to explain to patients, I'm like, look, I know that we're going to induce your labor a week before at 39 weeks. Your due date doesn't change.
Your due date doesn't change. Say that again.
Your due date is the same. No matter when your baby is born, you are going to be delivered at 37 weeks for your gestational hypertension.
Yes.
But your due date is not changing to that day.
Right. That's a hard thing to conceptualize. So I try to, your due date is when you are 40 weeks.
Yes.
By the numbers
280 days.
Right then. Exactly then.
And that's not going to change your entire pregnancy, no matter what.
Nope. I love that. And that's a hard thing to figure out sometimes too. We use so many weird numbers and abbreviations all the time.
Yeah, there's way too many abbreviations.
Too much. Brings us straight into this. When is a delivery considered preterm?
A preterm delivery is anything prior to 37 weeks gestational age.
And I like that question because I feel like when pregnant individuals go for their next pregnancy and they have to fill out paperwork, they are the ones responsible oftentimes for writing down term or preterm.
Yeah.
But it doesn't always say the gestational age on the forms they fill out,
Yeah.
which is very confusing. So yeah, 37. I think that's just helpful for people
37
to know.
weeks.
Yeah.
That is, I didn't
Right?
think about that.
I know. And we always, I mean, so many times they will recall, oh, no, I delivered at this many weeks. And I'll be like, well, this says it was term. They're like, no, it was 35 weeks. But they
Yeah, they
sometimes don't
didn't
know the
know.
difference
Yeah,
between term or
yeah.
preterm. Yeah. That's why we're educating people.
Love it.
What's a normal fetal heart rate?
Well, it depends on how gestational age, but in general, 110 to 160.
I love it. See, and that's why I wish this was a board exam. I'd be like, gosh, she's so smart.
It's important to know, though, too, because I'll have patients who come for their first amenorrhea or first visit after having IVF.
Yeah.
And their baby's heart rate is 175. They're like 8-week fetal heart rate.
Yes.
And I'm like, it's okay. That's still normal. Or sometimes on physician community Facebook groups, not to call anyone out.
Yeah.
Online, people will be like, oh no, I went for my 10-week scan and my baby's heart rate was 180. It's too high. I'm like, heart rate scales to body mass. When you're really little, it goes faster. Elephants have a heart rate of like 30 or 40 because they're big.
Someone told me on the podcast, she mentioned that hummingbirds have a very, very high heart rate.
Ooh.
And I Googled it. I'm assuming Google's right because Google knows everything. It's super high and they're teeny tiny. So that totally like correlates very well.
Yeah.
And as fetuses get larger, their heart rates get lower a little bit.
Yeah.
So what we are saying our 110 to 160 is going to be after 24 weeks, I would say. That's a safe-ish way to say it. But when they're teeny tiny little nuggets, super fast.
Yeah.
We like super fast.
Yeah.
I like super fast. Question number 6 here. At how many weeks during a pregnancy should the anatomy ultrasound be done to look at all the parts of a fetus?
18 to 21 or 22 weeks. I don't like to push it that far. It makes me nervous.
I know. And I like that because for patients to know, and in our world, that's our big important ultrasound. Like if you're going to skim on ultrasounds for whatever reason, or if you're not able to get them or whatever, this is the one to be like, I got to get that 20-week anatomy scan.
And a good one.
Like 18 to 20 weeks. That's our sweet spot. I like to say. Let's see. How does an ultrasound estimate the weight of a fetus?
Also depends on gestational age, but in general, 16 weeks plus, we take 4 measurements: the circumference of the head, something called the biparietal diameter that is across the baby's head, but if you're looking at like a cross section of it, like if you cut through your head like this, you're measuring from here to here. The circumference of the abdomen at a very specific spot, and how long the femur measures, the thigh bone. And then you use those and you put it in this algorithm chart thing and it magically pops up.
And that thing, for any sonographers listening, when you do something on a machine and then you transfer it over to the computer system, if those two things don't match, you're in a world of hurt. Because I've had that happen before where the machine is one package, the computer system has a different package. So the machine where the ultrasound was done will say the baby's weight is at the 40th percentile. And they get over to the computer system and it says like 10%. And you're like, wait, what? But those can be way weird and off.
It's because there's different growth curves.
Yes.
From different authors.
Yes.
So you'll get something on the machine that then is Hadlock in your, and you're like, Hadlock, here we go.
Here we go. And then there's different Hadlocks.
Yeah.
By the year of which the data was published. So you can drop down and get I think 15 different options. And it's like, why? Why is it that hard?
Right.
Let's simplify stuff. I know. This is a fun question. I like this one. What makes up amniotic fluid?
Also dependent on gestational age, but the good patient understanding answer is that amniotic fluid is baby pee.
I love that. When people realize that, they're like, wait, what?
I know. It's okay. It's sterile most of the time. And when it's not, we need to know about it. And it's baby pee.
My also follow-up question for providers is, I said this one time, I'm like, it's kind of salty. And my friend was like, how do you know that? And I feel like pretty much everyone in our world has been splashed or sprayed with amniotic fluid.
Many times.
And never on purpose. I hope not. But goodness gracious, that stuff is salty.
Yeah. Like that's the reason I have Apple Care. That's the only reason I need it is because the amniotic fluid that comes.
That's true.
You know?
That's
and I keep my cell phone in my
pocket
scrub
right there.
pocket and it just sometimes
sprays.
comes.
The sprays. Question number 9. Who should be offered Down syndrome screening in a pregnancy?
Everybody who's pregnant should be offered Down syndrome screening and diagnostic testing for that matter via chorionic villus sampling or amniocentesis if they want.
So true. Would you be surprised if I said pretty much every guest I've had, and I think you may be number 29 or 30 or something, right? Almost every guest I've had, and most of them are in the world of being a provider or have had children, all will say one of two things: family history, or if they're older. That's because that's still ingrained in most people's minds.
Okay.
Would that surprise you? Or
I guess not. There's a lot of things about every other part of medicine that I don't know.
Yeah.
Or that I heard one time on rounds when I was a medical
Right.
student and now I never think of that again. So sure, I guess that.
I know.
But
So
in my world and in
I
my
know.
head, that's just
I know.
blasphemous.
I know. Okay. This is one we got to get out there more because I feel like it's one of those there's the stigma. It's to me, I always relate it to breast cancer. People are like, I don't need to get my screening because I don't have a family history of it. No. Most Down syndrome is not quote unquote inherited from someone in the family. Most breast cancer is not inherited from someone in the family.
Correct.
So the screening, again, you can opt out of it if you'd like, but the screening should be offered to everyone.
And on that matter, I offer diagnostic testing. To everyone.
Yes. And that should be offered to. I feel like
should be routine.
Yes. And sometimes it's being missed or skirted over pretty quickly. So anyone who's pregnant and listening and is like, wait, my doctor didn't tell me about that. I have videos on that. Like, what is Down syndrome screening? How do you advocate for yourself? Print this sheet. They just make sure you know the questions to ask. Your provider should be bringing this up to you.
Yeah.
However, I mean, you got to advocate for yourself too. Always. We all do.
Yeah, absolutely. Absolutely.
Oh, this is a kind of fun one. And I think this one is missed a lot. What is carrier screening?
Carrier screening is looking for genetic diseases or syndromes that a partner or a pregnant person carry one gene for. There are things that you need 2 genes most of the time to create the disease. But if you carry your gene and the person you're having a fetus with carries the gene, then there's a chance that the fetus could inherit a copy of both of the abnormal genes. But carrier screening just reports things that you carry, not diseases that you have.
Yep.
Most of the time.
Yeah. And I see so many people who haven't been offered carrier screening in their GYN appointments. Like, hey, doctor, I'm thinking about maybe starting a family soon. Is there anything I need to do? And it's like, no, you're good. Take a prenatal vitamin, right? There's so many things, right? You should have carrier screening. We offer it to people once they're pregnant, but it would be so awesome if they could get carrier screening before they became pregnant.
Right.
That would be cool.
And
vaccines. Well, the
vaccine testing.
The live ones.
And just the preconception consults in general, just to optimize your health and your current state of affairs before you attempt conception.
Yes. That was all those questions. Then we have some true false ones. I started a contract recently doing consults, and I was aware kind of after the fact, maybe before a little bit. I was doing full pre-cons like all day long. The amount of time that goes into a preconception consultation to look at all of the history, I must have seen POTS constantly and Ehlers-Danlos.
Really?
Those two were constant. I'm like, I feel like there's an overdiagnosis going on in this part of the US. And I was like, interesting. But it was like I was running an internal medicine clinic. I really felt that way, which was hard at the time. But I'm like, this is great because when I have board coaching for new clients, I'm going to create cases surrounding some of these things that you just don't see. Like POTS, I mean, I'm not saying you don't see those frequently, but things that we forget about sometimes.
Right.
Because once they're pregnant, we don't do a lot different for them. We make some recommendations, but it's not something we think about every day.
Right.
Right?
It's cool.
I know. Like pseudotumor cerebri, that came up a bunch. And I was like, that's a great case.
That's a great case.
Isn't that great? Okay. I'm gonna start building cases.
Yeah, that's a good case.
Right?
POTS is much more frequent now after post-COVID, I think, also.
I totally agree. Totally agree.
But it's a tough one because some people need to be on medications that their doctors then want to just stop.
No.
I'm like, please don't.
Yeah.
I don't want her to be hypotensive and go extremely tachycardic. It's also not good.
It's like those thyroid patients where the pharmacists won't refill their medications and they have hyperthyroidism. And they're like, well, your doctor can't give you those medicines. You're pregnant. I'm like, that's literally our field. And then they go into thyroid storm because their pharmacist decided they didn't want to fill a prescription that their high-risk pregnancy doctor prescribed.
And like on that note, I am not going to prescribe you anything that hurts your fetus.
No.
I'm not going to do that.
No.
And also SSRIs are safe in pregnancy, no matter what your pharmacist or TikTok says.
Oh, is TikTok saying they're not?
Everyone's saying they're not, but TikTok is, or Dr. Google or
somebody like that.
A combination of.
Okay. Yeah.
Just stop all your meds just because you are thinking about being pregnant. Like, okay.
That's not going to go well.
No, it's not.
We have really good, nicer data now than we had 15, 20 years ago, particularly for SSRIs, which makes me happy that we have that data.
Absolutely.
And good documents now that ACOG released too, which is really helpful as well.
Absolutely.
Okay. All right. True, false questions. You ready? Rapid fire. Question number 1. True or false? A fetus can have hair while in the womb.
True.
Oh, you're so good at this. People are always like, yes. I'm like, no, true or false? You're so good. Question number 2, true or false? A pregnant patient's heart rate will increase during their pregnancy.
True.
Question number 3, itchy palms during pregnancy may be a sign of a serious condition during pregnancy.
True.
Question number 4, everyone should be screened for diabetes when pregnant.
True.
Question number 5, everyone should be screened for thyroid disorder when pregnant.
False.
God, I love you. Question number 6, someone with 2 prior cesareans has to have a 3rd cesarean.
False.
Question number 7, twins that are the same gender are always considered identical.
False.
Question number 8, no cheese is safe to eat while pregnant.
False.
Question number 9, someone trying to get pregnant should start taking folic acid before they become pregnant.
True. This is so fun.
This is so fun.
I know, I love it.
Question number 10, baby aspirin is an over-the-counter medicine that can prevent a certain type of high blood pressure during pregnancy.
True. Hey,
I mean, cheese and
too
rice.
Good.
Too good. That was fun.
That was really fun.
Oh, that should be board exams.
Yes.
That's what we should say. We should be like, dear ABOG, we would like the board exams to be rapid, true, false questions.
Redo your formatting.
Let's start doing that. We'll do like Zoom style or just in person. I'll go to New York. You'll come down here once a month, right?
Yeah.
And we'll do this and we'll do like a rapid fire, like what to do and what not to do for board exams or something like that. It would be so much fun.
So good. I
so
love
much
it.
fun. Well, thank you guys for listening today. And as always, I'm Dr. Lexi, wishing you a happy and healthy pregnancy.